I want to introduce onto our panel today, first of all, he's the consultant neurologist at Beaumont Hospital, Dr. Norman Delanty. We've also got Cora Flynn, who's the advanced nurse practitioner in epilepsy from Beaumont Hospital as well. And Grainne, Griffin and Maria Keegan, who are epilepsy clinical nurse specialists from Our Lady's Hospital in Crumlin. Give them all a round of applause. Where would you like to begin? Who wants to be first up? I know this is like being in school, it's like being in class. Oh, thank God for you at the back, whoever you are. You've broken the ice immediately. Thank you. Let's get a microphone to you.
Sorry, I just want to know, could you explain vascular seizures to me?
Who wants to deal with that? Sorry, can you repeat the question, please? The microphone needs to be turned up a little.
Vascular seizures.
So vascular seizures or vascular epilepsy basically just refers to the cause of a particular type of epilepsy that's due to, if you like, hardening of the arteries in the circulation of the brain. The more obvious consequence of that being a stroke, right? So an elderly person has a stroke. After a stroke, you've got about those individuals who have a stroke have about a 10% risk of developing epilepsy. Now, there may not need to be an obvious stroke, but a person may have hardening of the arteries in the brain or in the circulation of the brain that can predispose to epilepsy, usually in later life. And that broad term then is termed vascular epilepsy or vascular seizures.
Okay, who wants to go next? Gentleman here at the front. Hang on for 1 second, we'll get a microphone to you. As you can see, there's only one Paul and he's running, so just be gentle with him.
Thanks, Paul. What is the latest on the INFER project introduced about the 8th of February in Dublin?
INFER is an abbreviation for the Irish National Foundation for Epilepsy Research that was initiated by a number of us, including Colin Doherty and Mary Fitzsimons. It has recently undergone a name change to ERI, or Epilepsy Research Ireland, which is, and there's a board of Epilepsy Research Ireland. We had a sort of a scientific day earlier on this year with scientific presentations at the RCSI in Stephen's Green. But INFER has become Epilepsy Research Ireland, and there are a number of active members, people with a connection who either have epilepsy themselves or have a family connection with epilepsy, or on the board of Epilepsy Research Ireland, and they are beginning to get a database of individuals who will help with fundraising projects with the ultimate goal of funding research projects on epilepsy in Ireland along the lines of the type of research that was presented earlier on. But certainly Epilepsy Research Ireland are very much alive and well, and you will be hearing more about Epilepsy Research Ireland and being asked to maybe help with some of their fundraising projects, or at least to attend their fundraising events.
Okay, lady in the front.
I want to ask about the driving. People with epilepsy, obviously, when they're diagnosed with epilepsy, lose their license. The most traumatic, I think, result in actually having a diagnosis. However, the Brainwave literature refers to provoked seizures, and I quote, "In certain circumstances where there has been a provoked seizure, the 1-year rule can now be reduced to 6 months." And I wonder if somebody could actually clarify what that means.
Why does everybody look at Norman automatically? Don't think you're... I understand he's the neurologist, but don't think you're all going to get away with it speaking for the rest of the day.
I don't want to be hogging the panel by any means. My reading of that is that in the original law that was changed in 2004, where if somebody had a provoked seizure and the circumstances of that provocation, if you will, was reversed or treated, then the person would be off the road for 6 months rather than 12 months. Now, I would read that as, and I don't know whether Dr. Lynch would agree with me, as a medically provoked seizure. In other words, let's say, give you an example, women who are pregnant can develop a condition called preeclampsia, and if their blood pressure becomes extremely high, they can develop seizures, and then we call it eclampsia. Okay, so that's a medically provoked seizure. Okay, And obviously, those women will be treated, the baby will be delivered, and the woman will return back to normal in terms of the blood pressure. That's a medically provoked seizure, and that individual should not drive for 6 months. Similarly, if a diabetic takes too much insulin and their sugar drops very rapidly, then they may have a seizure associated with a very low blood sugar. That's a medically provoked seizure. So it's those circumstances I think the law refers to. I do not believe that it should be referred to somebody, let's say, with epilepsy who has a bad night's sleep or stays up till 2 o'clock in the morning and then the following day has a seizure or forgets their medication, as will happen, and then has a seizure the following day. I do not believe that that's a provoked seizure in terms of lifestyle. It's all about the use of language here, but I don't think it's not what that law refers to, in my view. I don't know if John would agree with that.
Can I maybe ask a question on that as well, Norman, in that who is it who ultimately passes judgment in a situation like that?
The three additional things that were added to the driving licensing regulations in 2004 all have to be signed off, so to speak, by a consultant neurologist, and that's actually in the law. So just to go over the three things again: a provoked seizure, what I would say a medically provoked seizure, 6 months. If somebody has only nocturnal or sleep seizures for 2 years or longer, but no daytime seizures, then that individual is allowed to drive. And the third one, if somebody has only what we call simple partial seizures, where there's definitely no alteration of awareness for a year or longer, that individual is able to drive. But it's the consultant neurologist who makes the decision.
I would agree with that. And I was just going to give a perspective from the question that you asked, Rick, because in the UK they have the DVLA, the Driving Vehicle Licensing Authority, who ultimately decides whether somebody can drive or not. And as you alluded to in your question, it's often the most dramatic thing in the first clinic visit when somebody's diagnosed with epilepsy and you say that they can't drive. So immediately there's a deterioration in the relationship between the doctor and the patient. And I think that's unfortunate, and I think that should be redressed. I think we should move more towards a model that they have in the UK where the neurologists can give their professional opinion and are often asked to do that. But it should be separate from the doctor-patient relationship, because I think it does disturb that. But I would agree with Norman's interpretation of the thing. That's the other thing. I mean, it is open to interpretation, which we could debate about whether it should or shouldn't be, but I agree with Norman's approach.
Who's next? Gentleman in the front.
Right, thank you. Speaking about driving, thankfully I've just got back driving 2 years ago after being off the road since 1993. And it has been an absolute incredible release for me. But I have to say it has been mainly due to this man here, Dr. Norman Delanty. He has seen me through one of the toughest periods of my life since about 2001, and has oversaw right through to brain surgery. And I want to thank Dr. Delanty for that, and Dr. Jack Phillips. Thank you.
And in order to save Norman's blushes from the stage even further, do we have another question? Over here in the centre.
Hi. At what age do you become an adult in the epilepsy world? My daughter's 15, and is the transition from one hospital to the other, is it difficult or is it smooth? It's just something we're concerned about.
Okay, good question. I think it's something that we face on a daily basis, as you can imagine, particularly if children have been in our service for a long time, and the whole thought of moving away from the people that they're used to managing or talking to on a daily or weekly or monthly basis, or every a couple of times a year, it becomes a huge issue. I suppose by law, after the age of 16, they can't be admitted to Our Lady's in Crumlin. That's, and I think it's the same in Temple Street. The girls here can clarify that for me. So we start the process when they're 16. We suggest that moving on. They can still attend us in the clinic up to the age of 18, but 18-year-olds can't be actually admitted to the hospital. So the process starts. It depends on what hospital they want to be transferred to. Some patients may be well controlled enough that they can continue their care with their GP and link in with the neurologist maybe once a year. Others need a closer follow-up. So it really depends on where you live in the country also what the waiting list is like for the adults. Does that answer your question? It comes through the hospital, but also it is patient-led as well, because we have some 16-year-olds that are ready to go into adults. Then we have some 18-year-olds that are, just about ready.
Okay, anybody else?
In relation to a VNS, does it have any connection with slow swallow after installation?
Does it have any connection with slow swallow?
Does it cause slow swallow or the
Or
slowing
difficulty,
down of the
like
swallow?
difficulty swallowing? Yeah. I mean, if the parameters or the adjustment levels on the vagal nerve stimulator are too high for that particular individual, it can cause some local side effects, including hoarseness, some throat discomfort, coughing, and sometimes difficulty with swallowing. But the thing is there are various things on the VNS machine or device that can be adjusted that should improve those kind of side effects or adverse effects. But it can be a factor, yes.
Anybody else?
Thank you. To be worth taking that side effect for the cure?
It would be worth taking that side effect for a cure.
Well, as I say, with adjustment of the vagal nerve stimulator, those side effects should certainly be either abolished completely or certainly minimized so that somebody has a reasonable quality of life. But you bring up an absolutely important point in what we call therapeutics or treating conditions in general, that we have to be careful that the side effects of treatment are not worse than the condition you're trying to treat. That's an absolutely very valid point and reminder, yeah.
Okay. Somebody had their hand up over there on the side, and we'll come back to that lady over there in just a second.
I'd just like to ask anyone on the panel, basically. I've heard that anyone with epilepsy should eat approximately every 4 or 5 hours. Now, what I want to know is, what do you do if, say, you can't get to your particular medication, and you need to sort of to be watchful of the seizures now. How often do you actually have to eat? Like, is it every 4 or 5 hours, or because I'm trying to figure it out, because if you can't get your medication, should you eat more to compensate for that, or should you just continue on as normal?
Eating regularly is important, so 3 regular meals a day, not going long periods of fasting, which may provoke a seizure for some. But with 3 times a day medication, the medication should be taken regularly, roughly 8 hours apart. Whether you've taken food or not, the medication should still be administered regularly. But for some...
Sorry,
go ahead.
If you're out, we say, and for some reason that you can't either you can't get to take the medication at the correct time that you usually take it, or even to say if you accidentally run out, if you are living on your own, then what? I mean, should you increase the amount of food that you eat, or the frequency that you eat to compensate for that?
Now, if you have a preference to taking your tablets along with food and you're out and about, maybe bringing a snack with you might be important for you. But for some people, maybe going to a twice-a-day schedule of medication may be easier for you.
So once you kind of keep your sugar levels up, in a way, am I right? Then you're kind of less likely to have a seizure.
That's one element of it. Would you?
But there's not. I mean, there's not a there's no absolute necessity to eat every 4 or 5 hours just for the sake of eating every 4 or 5 hours. Obviously, you could have a snack if you feel hungry or peckish like anybody else, but there's no necessity from the seizure point of view to eat every 4 or 5 hours. I mean, we try and get most patients into twice-a-day schedule. That's not always possible, but it's much easier for a lot of reasons to be on a twice-a-day schedule. And of course, you can also, in terms of taking the medication, you can buy a 7-day pull-out pill box, so that if you're going away, you can take out, if you're going away somewhere on a Thursday, you can take your Thursday pill box day with you. So, you know, I wouldn't get hung up on necessarily having to eat every 4 hours if you don't feel hungry. I don't know if Maureen and Maria would agree.
I suppose it differs for everybody, and different things will trigger seizures for different people. So if it's very clear that you are more prone to having a seizure if you haven't eaten for a long time, well, then it would be important to bring a snack with you. And just remembering to try and plan ahead. I think that's a big thing. Planning ahead. If you have a good idea that you're going to get delayed, or there's a good potential or possibility of getting delayed, bring your medicines with you and a snack with you, and then that avoids the problem.
I think just before we get into the next question, I've been asked to more. Sorry, Norm.
Sorry, Rick. Just one other point. It comes up a lot, and it's a very important question about diet and epilepsy and diet and seizure control. Just so you might see this on the internet, there is a lot of interest in the last couple of years on what's called a low glycemic index foods and seizure control. So basically the idea is that if you eat more natural carbohydrates, so whole grains and things that give you a more sustained rise in blood sugar over several hours, rather than like if you take a bottle of Lucozade or a candy floss, your sugar will go way up, and you'll get peaks in your sugar. But there is some evidence from a number of centres in the States that the low glycemic index carbohydrates, the more natural foods, are better in terms of seizure control. But that's sort of an area of interest that hasn't been proven across the board.
Just the question I've been asked to ask is everybody warm enough or cold enough? Are we at a nice median temperature? Are we okay? Just anybody has any problems with too warm or too cold, then just give me a wave. We're going to go to this lady over here, and then this lady here in the yellow immediately after her.
Hi, my son has recently been diagnosed with epilepsy. He's 7, and I only noticed yesterday that he's starting to have absent attacks. Now, I don't really fully understand what's happening to him when he's having those couple of seconds of absences. When he has a seizure, I can see it. I can see the shaking or whatever's happening to his body. But when he's having those absence attacks, I can't actually understand what's happening behind him staring for those couple of minutes, or couple of seconds, should I say. And secondly, should I actually diarise them?
Okay. When obviously the absences, as you said, are new. So what you've seen. Oh, he has had them?
Yeah, he originally had them when he was 2 years of age, and we had an EEG done, and we were told the EEG was actually normal and that he might possibly grow out of it. So then 6 weeks ago, he's 7 years of age now, he had a full seizure. Oh. And since then, he's been diagnosed with epilepsy. But I noticed yesterday, he's starting to have a couple of absent attacks again, you know.
Okay, so the absences had gone for a while, is that it? Yeah. No.
They never really left him.
Okay. And is he on medication?
He is. He's on Epilim now.
Okay. And working up with the dose?
Yes, we just increased it 2 days ago.
Okay, all right. You're wondering what happens to him when he's having... He literally blanks out. That's what Brainwave actually have a book out written for children called My Lights Go Out, which is a simplistic way of describing how a child, what it feels like for them. So for those few seconds, there's a gap in time for them. So he wouldn't be aware that this is happening. Okay, so it's important for school children, if they have an SNA or of a teacher who's observant and sees what's happening, that they make up for that little gap in time if they've realised that they've missed something. Okay, and if it's happening on a regular basis, you asked then, should you put in the diary? Yes, because obviously that gives an indication then of how effective his medication is. Okay?
I mean, remember that the absence is still a seizure. So it means that, I mean, obviously it may be hard to control them, but it means that the epilepsy is active.
Just on that point as well, I think it's particularly important to point out that children that are having seizures during the school day, it is important that teachers are made aware of what exactly happens for the child, what is expected and what to do for them, and also that some agreement you come to some agreement between yourself, the teacher or the SNA, that they feed back to you the number of seizures that are happening or exactly what they're seeing. Because there are times where we've gone back to parents and they've been telling us that there's been no seizures, but we've asked what's happening in school, is there anything happening in school, and they've said, oh, I don't know. And when they've gone back to the teacher, then they realise that there still is seizure activity. So it is important that something is agreed. Yeah, either the teacher or the SNA. It is important that you are aware of the seizures happening. Yeah.
And again, maybe just, I should have asked this at the very beginning, but if you can stand up while you're asking your question, it just means we can see your lovely faces and say hello. As opposed to disappearing in a sea of heads. I can see you up here quite easily because I'm on my podium, but the panel can't down there. That lady next.
Actually, this is on behalf of my son Peter, and he wants to know what's the percentage of seizure-free with the VNS? After 2 operations.
Vagal nerve stimulation is not a cure for epilepsy. The outcomes of VNS therapy, maybe half, 30 to 50%, may have the frequency of their seizures reduced considerably. But other outcomes that need to be considered is it can lessen the severity of seizures. It can also improve the postictal or the recovery phase after a seizure. And if one feels a warning or an aura, they can also use the magnet, which in some individuals can abort the seizure. So if you get any of these positive outcomes, you can then maybe look at the medications, and there may be options then that one can reduce the medications. And for some people, it has reduced the attendance to the emergency department or the less administration of emergency medications. So what I'm trying to say is VNS therapy is not all about counting seizures. For some people, they do have a marked improvement on their seizure frequency, but for others, there are many other improvements, and including cognitive improvements and alertness as well. So it's really looking at the whole picture rather than just counting the seizures.
That it would be worth going down that road after having 2 brain surgeries?
It may be worth considering, yes.
Yeah.
We do have 1 or 2 patients seizure-free.
Okay, Peter, so I hope you're listening at home.
Hi, Peter.
Perhaps really briefly before we go to the next one, just because VNS has been mentioned on more than one occasion, for those people who don't know what it is, could we just get a really brief explanation of what it is and how it works?
VNS therapy is a pacemaker device that's implanted just on the left-hand side of the chest, and then there is a wire that leads from the device up into the vagus nerve. It's coiled around the vagus nerve. I always describe it as the vagus nerve being your M50 nearly of nerves between the brain and the rest of the body. And it is programmed by an external computer, and it stimulates the vagus nerve. And by stimulating the vagus nerve, which goes up through the back of the brain into the brain stem and thalamus, it can reduce excitability, which can help seizure frequency.
Okay, I just want to make people conscious. We have about 20 minutes roughly before the work groups begin, so we're kind of relatively limited on time. So I'm going to try and get through as many questions as I can. The lady over on the side.
I'm quite newly diagnosed with epilepsy, and I had meningitis over 20 years ago. I just wanted to know what the connection is. Is it definite, or I don't know that much about it?
Do you know if it was bacterial meningitis?
No, viral.
Viral meningitis. Yeah. I mean, meningitis is certainly meningitis. Meningitis is any CNS infection, any infection of the nervous system. That could be meningitis where the lining of the brain is affected, or encephalitis where the brain substance itself is affected. Is what we call a risk factor for the later development of epilepsy, and including other brain insults like head trauma, significant head trauma. And of course, begs the question, why, if you have a brain insult like meningitis, does it take so long to develop epilepsy? And I can tell you that's one of the big unknowns in epilepsy. It's a process called epileptogenesis. In other words, how epilepsy develops over time. And you'd go to scientific epilepsy meetings in the States and elsewhere around the world, and this is one big topic that's all, discussed, but it's not understood why it takes so long for epilepsy to develop after something like meningitis. But it's certainly a risk factor.
Okay, who's next?
I just want to ask a quick question. Is there any new medications available for people suffering with temporal lobe epilepsy?
So there's the most recent medication that was approved for what we call the refractory or difficult to treat partial epilepsies, of the most common being temporal lobe epilepsy, is a drug called Vimpat or lacosamide. So that was released probably about a year ago. That's the most recent medication, and again, it's not a cure, and it might, it's something that could be tried. In the next year, there will be another medication hopefully released called retigabine. I'm not quite sure what they're going to call it in terms of its trade name, but this again will be approved for something like difficult to control epilepsy, temporal lobe epilepsy. So there are, thankfully, new medications coming on stream that might help individual people who've been hard to treat in the past. But as yet, there's no magic bullet medication that's in the pipeline. But there are new medications being developed all the time, and we will have one more medication next year, hopefully.
Anybody else? It was when I said we have to squeeze in all of our questions that you all decided to dry up at exactly the same moment, wasn't it? I knew I was jinxing it when I said something. We're not. There's a lady with a question here in purple.
Is epilepsy hereditary?
I think we probably covered that earlier on this morning when we were talking about the genetics of epilepsy. So yes, it can be. And I guess what you're meaning is that if it's in your family, is that possible that's the reason you've developed it? Is that your question? So
I was talking about my offspring.
Your offspring. It can be, yeah. And again, you can't until it appears. You have children?
Yes, I have a boy and a girl, but my father had epilepsy. Well, he had 3 episodes of epilepsy, or he had 3 seizures, we'll say, and I wasn't around to see them. My uncle always had epilepsy, and I didn't hear about that till recently. And my daughter actually came home from college yesterday, and she's sick today, and she's had, maybe it's just because I'm here and I'm extra aware of all this staring. She's sort of been staring all week, and, people have been, wake up, and she's been really out of it, and I just want to know.
Yeah, I would agree with Maria. As we heard this morning, epilepsy definitely can be hereditary. Remember, when we use the term epilepsy, it's just a description. There are many, many different types of epilepsy. But some types are definitely more hereditary than other types. But if you take everybody with epilepsy, let's say the risk of developing epilepsy in anybody's lifetime is probably 1% to 2% over the course of a whole lifetime. And if you take the risk in family members of that 1% to 2%, in broad terms, the risk of offspring developing epilepsy would be about 5%, as distinct from the 1% to 2% in the general population. But there are some families where it clearly runs quite strongly, like you've described.
More in women than in men.
For a small subgroup of epilepsy types, it can be more frequent in women than in men, but usually associated with some other abnormalities of the cell, but not necessarily more women than men.
Okay, in the centre.
What's the likeliness of epilepsy fading away on its own?
Going away on its own.
It's like how long is a piece of string, isn't it?
I'm not going to give you a statistic or a number on that one, because again, it depends on the type of epilepsy. In pediatrics, many children will develop different types of epilepsy, and they will, and the phrase that I'm sure Marie and Grainne not necessarily use all the time, but hear all the time, is that they will grow out of it. And that's true for a lot of childhood epilepsies. Some almost guaranteed to go away, but not all the time. The one thing that also one can say about, but it can happen in adults as well, but we can't necessarily predict that people will spontaneously stop having seizures when they were previously difficult to control on the same treatment, but it does happen. But there are no fixed rules in epilepsy. Everybody is different.
I actually have a question here from a lady who didn't want to stand up with a microphone in front of a room full of people, which I can easily understand, surprisingly. She wanted to ask the panel, if you end up in a different time zone, for example in the United States, 5-hour difference, do you continue with your 8 a.m. and p.m. medication, which then becomes 3 a.m. and p.m., or should you alter your schedule?
Sorry, just say the last bit of that again.
If you end up in a different time zone, do you continue with your 8 a.m. and p.m. medication, which would then become 3 a.m.?
We'll see what Grainne says, but this might be one where we might have differences of opinion.
I was actually going to say that. I think it's different for everybody, and again, I'm just going to echo what Norman said there. You know, epilepsy is different for everybody. And from person to person, some people will be more dependent on their medication and really sticking rigidly to their times. And if you know, and if I suppose I'm talking from a pediatric point of view, particularly parents can often tell us that even if the meds are late by half an hour, they have a seizure and that's it. And sometimes it can be like literally on the button that they'll have a seizure. So I would say if that's the history that somebody describes to me, I would be inclined to say you need to stick to your time within reason. And the practicality of that has to be assessed as well, times, flight times, etc., etc. I think if somebody is reasonably well controlled and it's pretty clear that they're not very rigid, like they have missed the odd dose here or there, it happens, and it's clear that they're not at high risk. You also have to keep in mind the length of time that somebody's going to be travelling for. Is it a week, or is it 3 weeks? Is it a month? Is it 6 weeks? If it's going to be a prolonged period of time, we often do advise parents over a period of a week before they travel to work with the time and changing the times to suit the period of time that they're travelling. This isn't an easy answer. I think it's case dependent. I think that's what I'd have to say, and my best advice would be, if you're not sure, ring your epilepsy nurse specialist or advanced nurse practitioner and just get them to talk through with you. That's the best answer.
Norman has a slightly mischievous look, which leads me to believe that he'd like to have a word as well.
No, I mean, I would absolutely would agree with Grainne. If obviously you're getting history where the taking of medication has proved historically to be very important. But, I mean, remember, 8 o'clock in the morning in Dublin is 3 o'clock in the morning in New York. Now, I'm not a great fan of waking people up in the middle of the night to take their medication. So what I generally say is, if somebody's going to the east coast of North America, on the first day, the day of travel, is to split the difference by about 2.5 hours, and then once you get your first full day into the local time zone, just take it at the local time zone. Now, of course, again, there are all individual factors. If people are just going away for a weekend, probably not worth it. If people are going for a long period of time, I would say absolutely get into the local time zone, but I'm not a great fan of waking people up at 3 a.m. in the morning because it's 8 a.m. in Dublin. But
well, I would be in agreement with that, Norman.
Remember too that sometimes the actual travelling part of it can be the thing that's going to upset the whole seizure control bit. So you have to factor that into it as well. So we often advise parents, if they are travelling a long distance or going on a long haul flight, to make sure that the children, in our case, and I guess it's the same for adults, get plenty of sleep beforehand so that you're well rested going into your journey. So it might help with the seizure control at the other side.
Okay, who's next?
Hi, my 3.5-year-old son has dose syndrome, and I just want to know, every time when he started on Epilum and when the dose was titrated higher and higher, he always reacts very well to it initially, and then goes back to having, it seems, even more seizures. So I just want to know, is it a more positive sign that he reacts well initially, or is it a not so good sign that he reacts well and then, it stops being effective?
I guess there are positives and negatives there, because the positive is that you see that there is an improvement when you up the dose. The frustrating part of it is then that it seems to be short-lived. And we would certainly in our experience, we would see children who become what we call drug tolerant quite quickly. It's like the dose of medication, each time they go up, you get some positive response, but it's short-lived. And sometimes we have to, if you've tried, we follow the basic international guidelines, and you try a dose for an appropriate length of time at an adequate dose. So if that's not effective after several titrations going up with it, it may be time to consider adding in a second drug.
Yeah, he's just started on rufinamide as well.
Okay.
And again, after 2 days, he hasn't had anything now for 3 days, but I don't want to be hopeful because that's the way it went with the Epilum as well.
Yeah,
but,
yeah.
So, I mean, I just wonder, you know, if a child is going to be, you know, if the medications aren't going to work, is it more likely on a child that gets drug, you know, that has a reaction and then the reaction stops, or is it? I don't know whether it's a good sign in general or a bad sign in general that it works and stops working.
I guess, you know, as I said, there are positive and negatives. It's positive that you do get the response, but the negatives then are that you've left with the response for a short length of time. So it's like we were talking about the pharmacogenetics. You know, if we knew how each child was going to respond to a medication, it would make it so much easier. But we are quite often, unfortunately, and it does look like we're shooting in the dark, but it is trial and error, and you hope that you'll get there. And sometimes it can actually be a combination of two drugs, because rufinamide and some other drugs actually help one another along. So, you know, don't give up. That's the way to say.
Okay, anybody else?
John, did you want?
I would just add to that whatever the cause of the person's epilepsy, it's not an unusual phenomenon. The phenomenon you describe, where a patient has a medication like Epilum, has an initial good response, and then that response tails off, or dramatically tails off in some cases. And it's not that infrequent that we see that for almost every anti-epileptic medication that the patient goes on. And in my own experience, people, particularly children who have bad epilepsies, that is rather more likely to happen, that the pattern of their response to anti-epileptic medications is that they have an initial good response or reasonably good response, and then that tails off. And the mechanism of that is very unclear. There would be ideas that certain anti-epileptic drugs would share a common transport across, say, the blood-brain barrier, and that whatever the structure of the protein that carries it across, if that's carrying the same drug across in all occasions, then it's going to result in the same phenomenon. But it's not really as clear as that. We don't really understand why that is the case. So it raises a lot of very interesting points. But what I would say is, I think your question was whether it's a good sign or a bad sign. It's neither a good sign or a bad sign. We don't really understand why it happens.
We have a few more minutes if anybody else has another question. Last chance.
On from that, you know, when somebody continues to fail medication, then dietary options and VNS therapy at a young age can still be considered. Yeah, the ketogenic diet would be one for children, yeah.
Hi, just Aisling here from Brainwave. What would you say is the most important information a patient should bring to their appointment? Because we keep getting asked that.
The history of the drugs that they have tried, the maximum doses that they have got up to, and why it was discontinued is very important. A family history and a medical history is also important. And the description of the seizures, who has witnessed the seizures, the frequency of them, how long they're lasting, would be the main things that would make the first visit that little bit easier for both.
Yeah, absolutely, and it's particularly for the first visit, if somebody can actually accompany a friend or a family member, accompany the individual to the clinic to give that eyewitness account that Cora was talking about is very valuable. I don't know, in paediatrics there may be other...
From a paediatric point of view, there's a couple of additional things. We'd always ask parents to link him in with the teacher and also the services that they're linked in with, just to see if there are any particular problems that they have. And obviously then they can be brought up in clinic with us. So just to do that the week or two before clinic visit. Also to bring your diary with you. It can be really, really helpful, and sometimes parents can get a bit sick of doing diary or keeping diaries week in, week out, a day in, day out. But where kids are having very frequent seizures, sometimes when that is a bit troublesome and tricky to do, we would ask that the week or two beforehand that they would pay particular attention to their diary and record of seizures. Where kids are on a lot of drugs as well, sometimes it can be useful to actually bring the bottles with you. There can be different strengths, and pharmacies can make up different preparations, and just to be clear that if it's 5 mils, 5 equals 5 milligrams, etc., etc. The eyewitness is particularly important, but where you can't get an eyewitness to come to the visit, particularly during 9 to 5 working hours, it can be difficult. Sometimes a video clip can be useful as well if you can have it on a mobile phone. I think that's it.
And I think we've time just for one more question, although this gentleman here at the front, have you got something you want to say in the back of that?
One of the meds I'm on in the past year has come in 3 different preparations, basically the same producer, but come in different sizes, and so that they may be the same product, but they're getting more and more awkward to eject from the silver paper, and the pharmacist tells me it's the same drug, and I was wondering, like, is there any way of controlling the way things are happening? You're getting more and more cuts and bruises in your fingers. Is there anything can be done about it? And
I think you need to really emphasise to your community pharmacist that you want the same medication, and I think it's your right to ask for that as well. Some people, and I think the other thing then, if you are getting a mixture of different brands of medications, if they are affecting your seizure control, to highlight that to your pharmacist as well.
And is there any way of getting, I used before have a sort of a warning before my seizures would happen. And some years back, that warning disappeared. If I got any warning, I could sit down. The warning disappeared, with the result that I have no tip off at all. Is there any anybody here got an idea of how I might get the warning back?
No, unfortunately, and the seizure patterns can change in individuals over time spontaneously, and sometimes medications can affect it. And as you're implying, the warning is often seen as a good thing because people feel that they can get themselves safe. But the short answer is, can we bring the warning back for you? Not to my knowledge, no. Your other point about the tablets brings up an important point that's very close, I know, to Brainwave's heart in general terms, about going back to your chemist, and you might meet a junior chemist or whatever, this issue about generic substitution. And in epilepsy, we would strongly discourage generic substitution, because with generic medication, the variability in the blood of the blood level may be more than the medication you're already used to. So I think, this thing about generic substitution, I think the epilepsy medications that's accepted now are going to be exempt from enforced generic substitutions. Isn't that right, Paul? But make sure, every time you go to your chemist, particularly if it's not your usual individual who knows you and your family very well, if it's somebody in maybe training or just new to the pharmacist, make sure you get the same medication you always get, because there can be mistakes made, unfortunately.
Now, I'm afraid our time is up, and we literally have time for one more question, unfortunately, and that's it. And it's the lady in the pink, just 3/4 the way down.
I'm sorry, just going back to VNS, you got me worried there earlier. I have a 9-year-old that has a VNS installed, and he's gone from eating very well to getting a peg fitted at the end of the month. I'm just querying, should I get a second opinion?
the fact that he's getting a peg in, is that part of his condition? Has his condition changed over time? You know, his overall condition?
Generally not, but since that has been installed, the swallow slowed down, and they told me it had nothing to do with the VNS, but from what I hear today, I'm just a bit querying now.
But I mean, not knowing, you know, it may or may not have anything to do with the vagal nerve stimulator. In general terms, notwithstanding the terrible neurology resources in this country, people are entitled to get a second opinion in general terms. So, but you know, it may be part of the underlying condition rather than the VNS. In your son's case, I'm not sure.
For some people, they can lose a little bit of weight when VNS is implanted. And certainly there were trials in America, they were using it in obesity and implanting it in the abdomen. So it may be worthwhile reviewing the settings to see whether any adjustment may improve appetite, but whether or not his nutritional status may have changed for other reasons could not be ruled out either.
Just on that note as well, sometimes in the paediatric population we will steer towards a PEG to ensure that their nutritional needs are met, and as a result of that we don't put as much emphasis into trying to feed orally for different reasons. I don't know the full history there, but sometimes as a result of not pushing food orally, kids actually you will find the kids are less likely to do it, and it's just sometimes it's just easier to give everything through the PEG. So sometimes we do need to encourage parents to remember that they should try oral foods if they're allowed to.
And I'm afraid, unfortunately, the workshops are due to begin now, so that's where we have to leave our panel discussion for today. Can you please give a huge round of applause to Dr. Norman Delanty, to Cora Flynn, Grainne Griffin and Maria Keegan. Thank you.